Hey, this is Jim Hefner with the Student Physical Therapist. And in today's video, I want to talk about someone who came in with signs and symptoms of neurogenic thoracic outlet syndrome. Now, TOS is complicated to treat because the shoulder girdle is so complex. But then when we start tossing in terms like syndromes, that means there's often multiple things that are going on that just lead to that diagnosis. And usually it's a diagnosis of exclusion. So they put a syndrome on there because they really don't know how to define it. Thoracic outlet syndrome could be similar to piriformis syndrome or patellofemoral pain syndrome, where it is simply a collection of signs and symptoms that kind of say where the area of dysfunction is at. So with the thoracic outlet, yes, you have the neurovascular bundle that has to break through different points or has to get through different points. And it can get compressed there, but usually these people have other things going on. And that's what I'm going to talk about in my case study today. So with the person who presented was a 48-year-old female who's been having symptoms for about 3 years, mainly in her right upper extremity, but occasionally in the left upper extremity. Symptoms would increase anytime she'd raise her arm above 90 degrees, and then also typically when sleeping. And she said that she would sleep in pretty much a fetal position all the time. So she was curled up, her arm wasn't moving, and it was rounded internally, anterior relative to the rest of her body. So those are her two main aggravating factors. She didn't have any weakness, she didn't have any upper extremity atrophy, and her past medical history was pretty much non-significant or not pertinent. She had 2 hip replacements in the past, which is interesting because she's only 48 years old. But it didn't raise any other red flags for me. Aside from that, medication-wise, she took a recent steroid dose back that helped minimize her symptoms and allowed her to regain range of motion. But she said after that kind of wore off a few weeks ago, now she still has the range of motion, but the numbness is present with certain positions. So what I'm thinking right away for differential diagnosis is that it could be cervical radiculopathy. Yes, it definitely can be some compression coming from the thoracic outlet region. It's very complex there, so there's multiple things that I'd be looking at. And then also it can be some sort of distal compression. So if it's the median nerve, potentially it's getting compressed down at the carpal tunnel. So also, other past medical history would be a history of what she said, right elbow tendonitis that was never officially diagnosed, but she said the symptoms would go down the back of her arm, which could also potentially be some radial nerve tension that had been lingering from the past. Also, she has a history of neck pain, currently really not experiencing neck pain. So symptoms have been present for quite some time, and she's finally seeking some care for it. And from an examination standpoint, I'm going to talk about some anatomical things, just to give you a awareness of what she presents like. But that has nothing to do with her pain, and also that doesn't directly influence my treatment. But so when I talk about her posture, it's just a general observation. So with her posture, she kind of had that classic upper thoracic or CT junction hump, so usually indicating some stiffness in the thoracic and CT junction area. And then both shoulders were actually kind of depressed and downwardly rotated. So just from my postural observation, her shoulders were resting in a pretty good amount of depression. Let's see what else here. As we go through that, her upper extremity myotomes and dermatomes were completely within normal limits. And that's important to check because she has bilateral symptoms, and you want to make sure that she doesn't have any upper motor neuron signs and symptoms. So that with no mechanism of injury, and then also her other upper motor neuron tests, such as a positive Hoffman's, and then even are looking at lower motor neuron, Babinski and Clonus, those were all negative. Her shoulder active range of motion was lacking at end range, so she could raise her arms up and she'd stop about here, and then same thing with abduction, she'd stop about there. So she was lacking that end range, and she would also have the onset of numbness pretty quickly. And that numbness would start after about 3 or 4 seconds, and it would go away immediately once she brought her arm down. Passive range of motion still brought on numbness, but it was within normal limits. From a strength standpoint, she was strong here at 0 degrees. She was strong at 90 degrees in both flexion and abduction. And then her scapular muscle strength, so looking at mid-trap, lower trap, and serratus, she was unable to hold those positions at all. So weakness of the scapular stabilizers. Going down through my examination, I actually did not do the thoracic outlet syndrome special test because they have horrible diagnostic accuracy, but I did look at a median nerve test in supine, and she had significantly positive differences right to left, even though she's having symptoms on both sides of that reproduction of her numbness and symptoms taking her into the median nerve tension position. So really any sort of position here where you're elongating the hand, especially with shoulder depression, would recreate her symptoms. From a joint mobility standpoint, she had hypomobility in the thoracic spine and the CT junction, and that was just with PA assessment. And she had pretty significant or exquisite tenderness around the anterior thoracic outlet. And when I pressed where the pec muscle goes across onto the humerus, that would recreate her numbness on her right side. So if we're thinking thoracic outlet syndrome, if that's the term that we would want to give her, we can at least rationalize that, because by pressing here in the thoracic outlet, it reproduces her primary complaint of symptoms. But as I'll go along with this, you'll also see that she has some cervical dysfunction, some upper thoracic dysfunction, and the shoulder blade weakness. So those are all things that were contributing to just an overstress of her system. So as I mentioned, her main areas of difficulty were sleeping, lifting weights, and really reaching anything up overhead that would cause more of a numbness than a pain, really. So we talked a lot about, and with my education with her, I said, and she's a nurse, that's her background, so she has a pretty good medical and anatomical awareness. But we talked about how the nerves interact with that area, how the nerves run down her arm, how the median nerve reproduced her symptoms. And what I specifically told her was that her nervous system, if you think about the nerves as they exit through this region, they can be thought of similar to a garden hose that waters the grass. So I believe that's a Jason Silvernail analogy. But as the nerves exit here, go through the thoracic outlet and become individual nerves, they need to essentially, they need to help the muscles work. Now, so if there's any sort of compression here in the thoracic outlet region or down distally into the arm, that can cause some sort of neurogenic compromise. So we had the discussion that right now, positionally with certain things, when she'd raise her arms up overhead, those nerves would either receive some sort of compression or a tensile force that would cause that numbness to happen. And then so, and with that same analogy, it would be someone who, let's say a garden hose, if it needs to, the purpose of it is to water the grass, then just like if you put a kink in that hose, then it's no longer going to be able to do its job fully. So that's why she definitely has nerve-related symptoms. And now it's my job as the PT to educate her what those are and also gradually get her out of those symptoms. So from a treatment perspective, what I did was first, after the education of what's going on, then we did some manipulation to the thoracic spine just to desensitize the system or just kind of get things moving again, reset the system is what I told her. I did some mobilizations on the CT junction region. And then I started having her do some prone scapular retractions with her arms down by her side. I started there because I wanted a position that wouldn't reproduce her numbness. So we did some just prone scapular retractions with the arms at 0 degrees of abduction. We did the same thing, prone T's then, to get the mid-trap and some low-trap activation there. And then we just stayed at that range because anything above 90 was reproducing her symptoms. So we did some activation. I did manual therapy first, that sort of muscle activation. And then after that, that was the end of our first evaluation. So what I had her do for home program was lay perpendicular on a foam roller. So the foam roller is going across her thoracic spine in the back, and then do some thoracic extensions, maintaining a slight chin tuck just to keep everything open and expansive in the front. And so I had her do 2 sets of 15 of that. So that was her first exercise. And then the second one, to get the posterior shoulder muscles, get the low trap and the shoulder external rotators active, was a banded shoulder external rotation. So a huge emphasis on opening up the thoracic region, because we know that this region was causing that position, the anterior forward position, is what was reproducing her numbness. So that is a brief overview of a patient that I recently saw for having neurogenic thoracic outlet syndrome, or what we would classify as that. And I would just be wary that people are often very happy to diagnose TOS, and I think sometimes it can be a false diagnosis. And also, if you would look at, the patient would then go home and look at what the interventions are for that, there is some relatively scary surgeries, you could say. So a first rib resection, you have to do a pec minor release. But really, a lot of our education as physical therapists can be huge at reducing the fear associated with TOS, but then also really doing some postural strengthening to help open up the thoracic outlet region and minimize compression across the nervous system as the nerves run from the cervical spine all the way down to the wrist and hand.